This is the lecture for week 4, breast and thorax. Breast cancer statistics, the CDC in 2012. Breast cancer screening is the leading cause of death in women 35 to 65, second only to heart disease in women over 65. And 2,200 men have also been known to develop breast cancer yearly. Not counting some kinds of skin cancers, breast cancer in the United States is the most common cancer in women, no matter what race or ethnicity. The most common cause of death from cancer among Hispanic women, and the second most common cause of death from cancer among white, black, Asian, Pacific Islander, American Indian, Alaskan Native women. Breast cancer risk factors in women is increasing age. Age is the single most important risk factor for breast cancer. The chances of developing the disease increase with age. About 95% of women diagnosed with breast cancer each year are over the age of 40, and about half are age 61 and older. Another risk factor is history of a first-degree relative with cancer, early menarche before the age of 12, late menopause after the age of 55, nulliparity, meaning never ever having had a child, or having your first child after the age of 30. Breasts are mammary glands, secondary reproductive glands, and modified sebaceous glands. The female breasts are located over the pectoralis minor and serrata, anterior muscles of the anterior chest wall. They extend from the second rib to the sixth rib, from the sternal edge to the axillary line. A triangle of breast tissue extends into the axilla, which is called the talus Spencer. And the reason this is important is when you go to do your breast exams, you need to make sure that you're going all the way over to the axilla, up to the clavicle, and down below the breast. Breasts are composed of 3 types of tissue: glandular, fibrous, and adipose. Breast size depends on the amount of these 3 tissues. The amount of the tissue depends on the body size, the hormone cycle, the age, nutritional status, and genetics. Lymph nodes. The breasts of females and males have a lymphatic system that drains impurities and lymph into the blood. The pectoral or anterior lymph nodes are located at the lower border of the pectoralis major, inside the anterior axillary fold, and they drain most of the breast and the anterior chest wall. The brachial or lateral nodes are located in the upper humerus and drain most of the arm, and the subcapsular or posterior nodes are located in the lateral scapular border and deep in the posterior axillary fold, and they drain the rest of the arm and the posterior chest wall. The pectoralis, brachial, and subscapular nodes drain into the mid-axillary nodes. When you do an examination, first you're going to do inspection. You're going to begin the exam with the patient sitting upright, unsupported if possible, and undressed to the waist. You're going to work from the upper chest downward, comparing one side to the other, and you're going to inspect the skin of the chest wall for any cyanosis, pallor, scars, wounds, bruises, lesions, or nodules. And you can note the shape and symmetry of the thorax from the front to the back. You're going to observe muscular development and nutritional status by noting the presence of underlying fat and the prominence of the ribs. You're going to assess the respiratory rate, depth, and rhythm, and while breathing, you're going to note the symmetry of the chest wall movement, use of accessory muscles, bulging or retraction of the intercostal spaces, and the pulsations or any heaving. You're going to inspect the breasts of both male and female patients with their arms hanging loosely at their sides. Compare the patient's breasts, noting their size, color, symmetry, contour, texture, if there's any striae, any dimpling, the presence of edema or texture of redness. You're going to look at what they call the pierre d'orange, which is the skin of the orange, and how, if you think of the skin of the orange, how it's pitted. So you're looking for something like that also. So it's not the color or discoloration that you're looking looking for the actual pitting. You're going to examine, and you're looking you're going to have them sit straight up. You're going to have them raise their hands over their heads, and you're going to have them put them at their waist, and even have them lean forward, because you want to see if there's any puckering or if any part of the breast is being held back so that it can't fall forward freely. You want to examine the areolar for shape, color, and texture. You want to observe the nipples for color, size, inversion or eversion, retraction, deviation, or evidence of bleeding, cracking, or discharge. Ask female patients, like I said, to raise their arms up over their head, against their hips, lean forward. Finally lift breast to assess the lower and lateral aspects, and you want to observe the patient's axillary and supraclavicular regions for any bulging, retraction, discoloration, edema, rash, or infection. This just is a picture of different things that you can see in the breast. So in the one on the far left, you see it being held up. In 1A, you see an inversion of a nipple. 1B, you see an infection in the mammillary gland. 1D, you see the dimpling. The arrow points to it. Breast lump or mass, it can be benign or malignant, can be caused by various medical conditions, such as fibroadenoma, which is round, lobular, or ovoid. They are firm, well-defined, singular, mobile, and usually non-tender. Fibrocystic disease or benign breast disease is well-defined, round, elastic, mobile, tender, and cis. And mobile means when you put your hand on it, it moves around. It's not stationary. Fat necrosis is rare. It can cause skin or nipple retraction. Mass is round and tender with ecchymosis. Abscess, which is also rare in women who are not lactating, but can occur around the areolar. Mass is economic and tender and can drain purulent discharge. And cancer is a malignant breast mass, is usually non-tender, firm, irregularly shaped, and fixed to underlying tissues. One thing that women can get, especially when they're nursing, is a mastitis or a blocked mammillary duct, which is quite painful. And what they need to do when they have that blocked duct is they need to continue nursing. They can use heat on the area. They can use and massage and stuff until they can break it up and get it out. The obstruction. Mastitis usually is treated with an antibiotic. Fibroadenoma usually occurs between puberty and menopause, and fibrocystic disease usually occurs between 30 years old and the onset of menopause, after which they become less noticeable or disappear. Breast exam, there's an internet site to go for that goes over breast exam that's pretty good. A clinical breast exam is done by a healthcare provider who checks the patient's breasts and axillary areas for any lumps or changes, any tenderness. If a woman is 40 or older, they'll have a mammogram close to the time of the clinical breast exam. For women ages 20 to 39, they have a clinical breast exam at least every 3 years. And for women 40 and older, the clinical breast exam combined with the mammography may find more breast cancers than mammography alone. And when used together, fewer breast cancers are missed. There's a number of different ways of doing a breast exam. There's the circular papillary technique, and then there's the lawnmower. There's also a spoke one where you start at the center and then you work out to the sides. I usually do the lawnmower one. I've done the circular one, but I like the lawnmower one better. I start at the axilla, and I can go up and down the areas. I go all the way up to the clavicle and down to the breast. And remember, when you're palpating, you want to get down to the muscle. You don't want to just do it superficially. You have to really press down and get to the muscle, because that's where you're looking for any masses or any tenderness. And also, you want to squeeze the nipple. You want to make sure that nothing's coming out of it, because if they're not nursing, you really shouldn't have anything come out of it. And with that said, you have to remember, anybody who's on antipsychotics, sometimes they'll increase the prolactin level, and they will have discharge from their nipples, just so that you know. Time for a breast exam. Best time is 1 to 2 weeks after the woman has her menses. And menopausal women, same day each month. Breast of the ages. The neonate. Female and male neonates will have enlarged breasts caused by the mother's estrogen. The breast will normalize within 2 to 3 2 weeks to 3 months, and the nipples may secrete a white fluid which is called the witch's milk. Pediatric breast development usually begins around age 10. During inspection, it is normal to note asymmetry during the growth period. This is the Tanner stages for female breast development. Tanner stage 1, no glandular tissue. Areolar follows the skin contours of the chest. Typically that's age 10 years and younger. Tanner 2 is 10 to 11 and a half. You have a little breast bud with small area of surrounding glandular tissue. Tanner 3 is usually 11 and a half to 13 years old. Breasts begin to become more elevated and extend beyond the borders of the areola. They continue to widen but remain in contour with the surrounding breast. Tanner 4, increased breast size and elevation. Areolar and papilla form a secondary mound projecting from the contour of the surrounding breast. That's usually 13 to 15 years old. And Tanner stage 5 is 15 and greater. Breast reaches the final adult size. Areola returns to contour of the surrounding breast with a projecting central papilla. And if you look to the right, you can see the different stages drawn out. Breasts throughout the ages, again, pregnant patients, increased level of estrogen and progesterone causes fullness and sensitivity early in pregnancy. Nipples and areola become more pigmented, and during second and third trimesters, growth of mammary glands cause the breast to enlarge, and palpation of nipple can yield the colostrum or the pre-milk fluid. Geriatric patient inspection, more pendulous or flatter breasts. Palpation breasts feel more granular. The breast tissue is not firm and elastic, and the inframammary ridge is often palpable. You want to reinforce the importance of a regular breast self-exam and mammograms. This is just a chart for the recommendations. American Cancer Society recommends that a mammography should be done every year starting at the age of 40. Clinical breast exam every 3 years between the ages of 20 and 39, and every year starting at age 40. The National Cancer Institute says every mammography should be every 1 to 2 years starting at the age of 40, and no specific recommendations for a clinical breast exam. National Comprehensive Cancer Network says every year starting at the age of 40, so they agree with the American Cancer Society. And the clinical breast exam is every 1 to 3 years, at ages 25 to 39, and every year starting at age 40. And then the U.S. Preventative Service Task Force, informed decision-making with healthcare provider ages 40 to 49, and every 2 years, ages 50 to 74. And that they don't feel that there's enough evidence to recommend for or against the clinical breast exam. So, a 55-year-old Hispanic woman presents with chief complaint of, I have a lump in my right breast. She denies pain in or around the area of the lump. She denies any trauma to her chest. She also tells you she is very nervous because her mother had breast cancer when she was in her early 50s and died. So what other further questions are needed for further investigation? Any discharge from her nipple? When did she first feel the lump? Any pain with or without the palpation? Has she ever had lumps or messes in the past? What medication is she taking? When was the last mammogram? If she's had one, she's 55, so we would ask that when was her last mammogram, and was it negative? Onset you're going to do your old cart: onset, location, duration, characteristics, aggravating factors, relieving factors, and treatment. So how do you focus your assessment? You're going to do a complete breast exam. You note that the lump is at the right breast at 1 o'clock, 2 inches away from the border of the areola, no erythema, swelling, or tenderness with palpation. And when you write up your script or your form to send her for her mammogram, you want to make sure you put that in there along with in your notes when you document where you find it. So you're finding it on the right breast at 1 o'clock, 2 inches away from the border of the areola, so that they know right where to look for it. And then a differential diagnosis would be breast cancer, a benign lump, so maybe benign mass it might be, but breast cancer would be your main one that you're going to be going for. It could be an intraductal carcinoma, if there was a nipple discharge. Breast cancer has a good prognosis when diagnosed early. Most lesions are found in the upper outer quadrant of the breast and axillary regions, just so that you know. They usually start off as not being painful. Your other differential diagnosis would be a fibroadenoma. It's round, lobular, ovoid. They are firm, well-defined, singular, mobile, and usually non-tender. A 23-year-old female, urgent visit, complained of left breast pain, started a week ago with increased pain, fever that lasted 2 days. She also stated her left breast is much larger than her right. So other questions that you're going to ask: have you had this in the past? Does she have a baby? Is she nursing? Any warmth or redness that she felt? You're going to do a complete breast exam, inspect and palpate the area, and you're going to note the location and size, and you're going to do your old card again. So your differential diagnosis would be mastitis. Risk factors for mastitis include breastfeeding during the first few weeks after childbirth, sore or cracked nipples, although mastitis can develop without broken skin, wearing a tightly fitting bra, which may restrict the milk flow, becoming overly tired or fatigued, previous bout of mastitis while breastfeeding, so if you've had it once, you're at higher risk to get it again. If experienced mastitis in the past, more likely to experience it again. Usually mastitis treatment usually involves antibiotics, usually for like 10 to 14 days, and pain relievers. Other diagnosis would be, and then they're going to have to adjust their breastfeeding techniques to make sure that they have to make sure they're fully emptying their breast while they're feeding, and making sure that their baby is latching on correctly. Other differential diagnosis would be a fibrocystic disease or a breast abscess. Male breast, you're going to inspect the nipple and areola for nodules, swelling, ulceration. You're going to palpate the areola and breast tissues for nodules, and if breast is enlarged, you're going to distinguish between soft, fatty enlargement of obesity and firm disc of glandular enlargement or gynecomastia. Male breast cancer occurs when malignant cells form in the tissues of the breast. Any man can develop breast cancer, but it is most common among men who are 60 to 70 years of age. About 1% of all breast cancers occur in men. Like I said earlier, at least 2,000 men are diagnosed with breast cancer annually, with about 450 deaths due to breast cancer occurring each year. In boys, hormones made by the testicles prevent the breast from growing, and breast cancer in men is uncommon because male breasts have ducts that are less developed and are not exposed to growth promoting female hormones. Men should also be aware of gynecomastia. It's the most common male breast disorder. Gynecomastia is not a form of cancer, but does cause growth under the nipple of the areola that can be felt and sometimes seen. Gynecomastia is common in teenage boys due to hormonal changes during adolescence, and in older men due to later life hormonal shifts. Certain medications can cause gynecomastia, as can some conditions such as Klinefelter syndrome. Rarely, gynecomastia is due to a tumor. Any such lumps need to be examined and work up. The thorax is a region of the body found inferior to the neck and superior to the abdomen. The superior aspect of the thorax is narrow, and as we descend downward, it becomes wider at the inferior aspect. Inside the thorax are your primary organs of the cardiac and respiratory system. Central compartment is the mediastinum, and in there you find the heart and the great vessels, the esophagus and the trachea. On either side of the mediastinum, you will find a pleural cavity with the lungs and associated structures, and inferiorly the liver. And one of the major functions of the thorax is to protect these structures. Another function is to serve as an attachment point for the upper limbs at the clavicle and the major site of the muscle attachment. This is just a picture of your thorax, showing the things that I was just telling you about. Skeleton of the thorax. Interiorly, the sternum has 3 parts: the manubrium, the body, and the xiphoid process. Laterally, you have 12 pairs of ribs. Ribs 1 to 7 are called true ribs. Ribs 8 to 10 are false ribs because they don't have their own costocartilage. Ribs 11 to 12 are floating ribs, no interior attachment at all, and posterior you have 12 thoracic vertebrae. When you look at the chest, you want to look at the shape, the symmetry of the thorax, front and back, inspect and palpate. You want to look at the angle of the costal margins at the xiphoid. You want to observe the patient's muscular development and nutritional status by noting the presence of underlying fat and the prominence of the ribs. You want to assess the respiratory rate, the depth, the rhythm of breathing. You want to compare the length of the inspiratory and expiratory phases, noting any symptoms of distress. You note the symmetry of the chest movement, use of accessory muscles, a bulging or retraction of intercostal spaces, pulsations or heaves. And you want to observe for cardiac impulse in the apical area, medial to the big clavicular line, in the fourth or fifth intercostal space would be where you find your PMI, point of maximum impulse. At the back, you're going to have the patient expose the entire back. Ask the patient to fold their arms across their chest, then move behind them. You want to inspect, palpate, and percuss the back for texture, lesions, scars, sinus tract openings. Note any deformities. Observe the skin over the iliac crest and the sacrum for redness and other signs of breakdown. In bedridden patients, you want to look for edema in the sacral region. You want to observe the bony framework, scapula, and the angle of which the ribs slope from the vertebrae. You want to ask patients to extend their arms in front of him or her and lower them slowly to their sides. Watch to see whether the scapula protrude outward from his back more than normal. Ask the patient to stand. Look at overall body posture. Assess their spinal column for alignment. Make sure the thoracic and lumbar areas curve appropriately and observe for any abnormal curvature. Thorax. You're going to evaluate tactile fremitus, and you put what you do is you put their hands on their back and their chest. You want to use the palms of your hands, put them on there, and you're going to have them say 99. Have them say 99, and you're feeling for the vibration. Assess respiratory excursion, palpate the costovertebral angle, and you're going to check the range of the spinal motion. A 20-year-old woman presents with a complaint of left-sided chest pain that worsens with deep breaths and cough. Started about 45 days ago. States she thought she pulled a muscle when she was working outside in the garden. Keep patient's health history in mind as you assess your chief complaint. So what questions are needed for further investigation? What were you doing when the pain started? How would you rate the pain on a scale of 1 to 10? Is it worse or better now? Where in your chest is the pain located? And have them actually put their finger on where the pain is. Does the pain radiate anywhere? What type of pain is it? Is it sharp, dull, crushing, radiating, throbbing, aching? Any shortness of breath? Any shortness of breath? Nausea or vomiting, fever, cough? Does anything make it feel worse? Better? Does activity worsen it? Does rest make it better? Have you had this type of pain in the past, and is the pain constant or intermittent? And when was the last time you had it? For how would you focus your assessment? You're going to observe the patient's general appearance. Are they short of breath? Are they diaphoretic? Do they have cool extremities? You're going to check their vitals. Auscultate their heart sounds for regularity, rate, gallop, murmur. Lung sounds. You're going to also check for a pericardial friction rub. And when you listen for a pericardial friction rub, you ask them exactly where the pain is. If you listen over where the pain is and you have them hold their breath, you can hear the pericardial friction rub if there's one. If it goes away, if you do hear one before you have them stop breathing, and it goes away when they stop breathing, then it's not pericardial, it's probably pleural. You're going to examine their neck veins for JVD, which could indicate heart failure. You're going to inspect and palpate chest wall for erythema, swelling, and pain, and you're going to get an EKG. At 23, she shouldn't be in heart failure, hopefully. So that shouldn't, but you're going to throw that in there. It's a differential diagnosis for now. Differential diagnosis, costochondritis. Most frequently affected age group is young adults between 20 and 40 years old. Costochondritis can also be found as an overuse injury in athletes. In particular, this condition has been identified in competitive rowers. Pain usually occurs over the second, third, and fourth chondrocartilages. Palpation is directly over, so if you palpate directly over the cartilage, generally will produce a point of tenderness. Costochondritis can also be found after a traumatic injury. For example, a car accident where the driver's chest strikes the steering wheel can cause the costochondritis. By injuring the ribs and cartilage on the front of the chest. Viral infections, usually upper respiratory infections, have also been identified as the cause of the costochondritis. What are other symptoms? Most patients with costochondritis experience pain over the front of the upper chest, the area of the sternum. Because of serious conditions, most importantly conditions related to heart problems, costochondritis should only be diagnosed after excluding other more serious problems. So you always want to make sure you rule out your cardiac issues first and then go to that. Costochondritis pain is usually worsened by activity or exercise. Often the pain is worsened when taking a deep breath. This stretches the inflamed cartilage and can cause significant pain. Touching the area involved can be extremely painful to the patient. Because of the many nerves that branch away from the chest, pain may be experienced in the shoulder or arm as well. When called T2 syndrome, the pain from costochondritis is accompanied by redness and or swelling in the area most tender. Otherwise, you don't get the swelling and the redness with the plain costochondritis, but T2 syndrome you will. So T2 syndrome would be another differential diagnosis. Chest pain, MI, angina, pericarditis, and pneumonia would all be in your differential diagnosis for this patient.